If you're working in an ICU right now and thinking about CRNA school, there's a truth that surprises a lot of nurses once they start applying. Not all ICU experience is equal. Two nurses can both say they worked in an ICU for 3 years. One gets interviews everywhere. The other gets rejection emails or silence. And both are confused because on paper they look the same. The difference is not just the unit name, it's not simply how sick the patients are, and it's definitely not just how long you've been there. What matters is the specific skills you build, the decisions you make, and the level of responsibility you carry when things go wrong. In this video, I'm breaking down the exact ICU experience and clinical skills programs are actually looking for, what strengthens your application, what quietly weakens it, and how to make sure your ICU time is moving you forward instead of holding you back. Why? ICU experience is non-negotiable. Programs don't require ICU experience just because it looks impressive. They require it because anesthesia is critical care, just practiced in a different environment. In the operating room, nurse anesthetists manage unstable physiology in real time. Blood pressure can collapse in seconds. Airways can fail without warning. Medications can change a patient's trajectory almost immediately. Programs want evidence that you've already lived in that world, that you've managed instability, processed complex data quickly, and stayed calm when patients deteriorated. ICU experience is the filter they use to answer one core question. Can this person handle the responsibility of anesthesia? Which ICU types are most valued? This is where a lot of confusion starts. Most programs strongly prefer high acuity adult ICU that includes surgical ICU, cardiovascular ICU, trauma ICU, and medical ICU, where ventilators, invasive monitoring, and vasoactive infusions are routine. Cardiac ICUs often rank at the top because of the exposure to rapid hemodynamic changes, advanced monitoring, and complex physiology. But here's the key point. The unit title matters far less than what you actually manage during a shift. If your patients are rarely ventilated, rarely on drips, or quickly transferred out when they become unstable, programs may question whether your experience truly prepared you. They're not judging the unit, they're evaluating the responsibility level. Ventilator management is a core expectation. One of the biggest differentiators among applicants is true ventilator competency. Programs are not looking for nurses who simply chart that a patient is intubated. They want nurses who understand why settings are chosen, how changes affect blood gases, and how ventilation interacts with hemodynamics. Nurse anesthetists manage airways constantly. Ventilator settings aren't optional knowledge. They're foundational. You should be comfortable discussing ventilator modes, PEEP adjustments, oxygenation strategies, and recognizing problems like auto-PEEP or ventilator-induced hypotension. If respiratory therapy manages everything and you're not actively involved in the decision-making, that gap will eventually show. Hemodynamic management and drip titration. Another area programs examine closely is hemodynamic management. That means hands-on experience with vasoactive medications such as norepinephrine, vasopressin, epinephrine, phenylephrine, and inotropes. But again, the focus isn't on hanging the drip, it's on titration, interpretation, and anticipation. Programs want nurses who understand how preload, afterload, and contractility interact, and who adjust therapy based on patient response, not just numbers on a screen. In anesthesia, there is no time to wait for instructions. Decisions happen minute by minute. Strong ICU experience shows you already think that way. If this breakdown is helping you understand what programs actually care about, not just what's written on a website, make sure you're subscribed to Wise CRNA. This channel is focused on strategy, not guesswork. ICU preparation, applications, interviews, and long-term career planning, all from a realistic, data-driven perspective. Invasive monitoring and data interpretation. Invasive monitoring is another major differentiator. Arterial lines, central lines, and advanced hemodynamic data are part of everyday practice for nurse anesthetists, but placement alone doesn't impress admissions committees. Interpretation does. They want to hear that you understand waveforms, trends, and what those values mean physiologically, that you can recognize subtle changes before alarms go off, that you can connect lab values, vitals, and patient presentation into a coherent picture. Programs are looking for ICU nurses who don't just react, they anticipate. Autonomy and clinical judgment. One of the most overlooked aspects of ICU experience is autonomy. Programs listen carefully for how much independent clinical judgment you exercise. Strong applicants can clearly describe situations where they recognize deterioration, intervened early, and communicated effectively with providers. They explain why they chose certain interventions, not just what they did. Nurse anesthetists practice with a high level of independence. Your ICU experience should reflect that readiness. Why high acuity? Experience matters more than years. This is where many applicants misunderstand the process. 3 years in a low acuity ICU often carries less weight than 1 to 2 years in a very high acuity environment. Programs prioritize depth of responsibility over length of service. If your unit doesn't regularly expose you to ventilators, drips, and invasive monitoring, staying longer may not make you more competitive. It's not about time served. It's about the level at which you're practicing. Common ICU mistakes that hurt applications. One common mistake is assuming that any ICU automatically qualifies. Another is being unable to articulate your role clearly. Saying, "I took care of ICU patients" doesn't demonstrate readiness. Programs are listening for insight, maturity, and clinical reasoning. If you can't explain your responsibilities with clarity and confidence, they'll assume your role was limited. How to strengthen your ICU experience right now. If you're early in your ICU career, be intentional. Seek out higher acuity patients when appropriate. Ask questions about why certain interventions are chosen. Learn the physiology behind what you're seeing every shift. If your unit doesn't provide the experience needed for anesthesia preparation, consider transferring, even if it's uncomfortable. Every shift should move you closer to anesthesia level thinking. Final takeaway. Programs are not counting your ICU years, they're evaluating your readiness. They want nurses who understand physiology, manage instability, think independently, and remain calm under pressure. If your ICU experience is building those skills, you're on the right path. If it isn't, recognizing that early gives you time to adjust. This isn't about gatekeeping. If you want more guidance on positioning yourself for nurse anesthesia school, from ICU strategy to applications and interviews, make sure you're subscribed to Wise CRNA. This channel exists to help you plan intentionally, not guess your way forward.